Welcome back to the deep dive. We are shifting gears today. Usually we're looking at, broad trends or big tech, but today we're zooming in, way in.
We really are. We're treating this whole deep dive like a procedural drama.
Yeah, exactly. But instead of a crime scene with yellow tape, our setting is a busy ENT clinic in Kolkata.
And the clues are microscopic. The tools, surprisingly low tech.
And I want to set the stakes right up front, because when you hear ear infection, you think, okay, some antibiotics, maybe a few drops, and you're fine.
Right.
But looking at the source material, it's deceptively high stakes. We're talking hearing, sure, but also facial paralysis, even life-threatening brain abscesses.
Absolutely. The ear is literally a gateway to the skull. If an infection breaches those walls, it's in the brain.
Wow.
And the fascinating part of this case is how a doctor figures out if that breach has happened without, immediately ordering an expensive MRI scan.
Right, the medical detective angle. So let's open the file. Our subject is Vinod, 35-year-old clerk. He walks in, and his opening statement is pretty specific. He's had discharge from his right ear for 6 months, and hearing loss for about 4.
And right there, before Vinod even sits down, the detective work begins. We have to profile the suspect, the disease itself.
So what's clue number 1?
The timeline. Vinod says the discharge started insidiously.
That's such a loaded word. Insidious sounds like a horror movie villain, something sneaking up on you.
It does, and clinically that's exactly what it means. It didn't just explode overnight.
So it wasn't a sudden, I woke up in agony situation.
No, if he said that, I went to bed fine and woke up screaming with blood on my pillow, we'd be thinking acute otitis media, maybe trauma, but insidious.
It means it's been brewing.
A slow burn. It tells us we are dealing with a chronic condition right off the bat.
Okay, so it's chronic. Now we have to look at the evidence, the discharge itself. Apologies to anyone having a snack, but we've got to get into it.
We do.
The notes say mucopurulent, yellowish, and profuse.
And this is where we have to dust off our biology textbooks, because mucopurulent is a massive clue. It's a mix of mucus and pus.
Okay, so mucus. Where does mucus even come from in the ear?
It comes from goblet cells. They're like these little factories that produce mucin. Now, here's the critical geographical detail. In the human ear, goblet cells are only found in one specific area, the lining in the middle ear, near the eustachian tube, tubotympanic area.
Got it. So if you see mucus, you know the infection is hanging out in that specific neighborhood.
Exactly, but it goes deeper. Goblet cells are part of the ear's defense system. They create this conveyor belt of mucus to trap dust and bacteria and march it out.
The mucociliary clearance.
Right, so if you see mucus, even if it's infected, it means the ear is still trying to function. The mucosa is alive.
Which implies there's a version where the mucosa isn't doing its job.
And that's the unsafe type. We contrast Vinod's condition with something called atticoantral disease.
The attic of the ear.
The upper part. It has bone, but it has no goblet cells, 0. So if an infection is rototilling its way through the attic, you won't see mucus.
So what do you see?
You see scanty, thin discharge. And instead of making mucus, it's doing something else. It's eating bone.
Eating bone. How?
Usually from a cholesteatoma, which is basically a skin cyst in the wrong place. This cyst releases enzymes that literally dissolve the bone around it.
Which brings us to the smell test. The notes were really specific about a fishy odor.
Yeah, this is distinctive. If you walk into an exam room and you're hit by this wall of foul, fishy smell, you are almost certainly dealing with that bone-eating, unsafe type.
And that smell comes from what?
Saprophytic bacteria.
Saprophytic. We should define that.
It's from the Greek for rotten material.
Yeah.
These are organisms that feed on dead and decaying organic matter.
Oh, wow.
So when you smell that, you aren't just smelling an infection. You are smelling the byproduct of bone and tissue necrosis. It's the smell of destruction.
That is a visceral image. But Vinod's discharge, it's non-foul smelling.
Which is the aha moment. It points us right back to the safe mucosal disease. It's messy, it's profuse, lots of yellow gunk, but it's not dissolving a skull.
Okay, so the slimy and smelly analysis is done, but the notes also mentioned a color palette. Vinod's was yellow standard pus.
But the color tells you so much. If it's brown or black, you're likely looking at a fungal infection like aspergillus.
What about bloody?
Bloody, we're about trauma or, a tumor. But the one that really keeps doctors up at night is actually clear fluid.
That seems counterintuitive. Clear sounds clean.
And that's a trap. If you see clear, watery fluid dripping from an ear, it might be CSF, cerebrospinal fluid.
Brain fluid.
Brain fluid. It means the barrier between the ear and the brain has been breached. That's a quiet emergency.
Okay, so Vinod is yellow and mucus heavy. He's safe for now.
So we've analyzed the physical evidence. Now the detective shifts to interrogation, the negative history.
This is a concept people outside of medicine sometimes miss, right? The things that aren't happening.
We spend as much time asking about what isn't happening as what is, because the negatives are what save the patient's life.
The doctor runs through this checklist. Fever, double vision, neck pain. Vinod says no to all of them. Let's start with fever.
Right. We aren't just asking about a low-grade flea fever. We are looking for a very specific pattern called picket fence fever.
It sounds like a landscaping term.
And the chart looks like it. Imagine a temperature chart that spikes incredibly high, 104, 105 degrees, with severe chills, then plummets back down, and spikes again. Up, down, up, down.
Like the pickets of a fence. What causes that specific pattern?
It's terrifyingly mechanical. It happens when the infection spreads to the sigmoid sinus, a major vein that drains blood from the brain.
Okay.
The infection creates a septic clot. Every time a piece of that infected clot breaks off an embolus and shoots into the bloodstream, the body reacts with a violent rigor and a massive fever spike.
So a no on that type of fever is a huge bullet dodged. What about the double vision? Why would an ear infection make you see 2 of everything?
It's all about real estate. The skull is crowded. The 6th cranial nerve, which moves your eye outward, runs right past the tip of the petrous temporal bone.
The petrous apex.
Exactly. If the ear infection digs deep enough, it causes inflammation there. Petrositis. That swelling chokes the 6th nerve, the eye muscle gets paralyzed, turns inward, and boom, double vision.
This is what you meant by high stakes, an earache connected to paralyzed eyes. This even has a name, doesn't it? The combination.
It does. Gradenigo syndrome, the classic triad. Ear discharge, eye pain, double vision. If you see it, you are in the danger zone.
So Vinod has no fever spikes, no double vision. The last on the checklist was neck lumps. Abscesses dripping down the neck.
It's pure gravity and plumbing. If pus build up in the mastoid bone behind the ear and it can't drain out the ear canal, it will find another way out.
It erodes through the bone.
It can. It erodes to the tip of the mastoid bone. Once it's out, it follows the muscles.
Where does it go?
If it breaks through the inner side, it trickles down the sheath of the sternocleidomastoid muscle, that big strap muscle in your neck. That's a Bizold's abscess.
And you'd feel that as a lump.
A boggy swelling, yeah. Or it can go to the back, toward the digastric muscle.
Yeah.
That's a Satelli's abscess.
So when the doctor feels Vinod's neck, they're checking if the plumbing has burst.
Exactly.
And Vinod passes the interrogation. No brain clots, no paralyzed eyes, no neck abscesses. So the doctor finally picks up the otoscope.
And this is where it gets incredibly visual. You look through that little window, and you have to interpret the landscape.
One image in the research really stood out, the wet newspaper look.
Vinod didn't have this, but I have to ask.
It's unmistakable. If you look in an ear and see a grayish, soggy mass with little black or white dots, it looks exactly like newsprint left out in the rain.
And that is?
Automycosis. It's a literal fungal garden growing in the ear canal. The dots are the spores.
That's gross, but very distinct. Then there's the lighthouse sign. This one's more dynamic. It happens in an acute inflammation. You have a tiny pinhole perforation and a milli-ear full of pus under massive pressure.
So what's the light?
When you shine your otoscope light on the pus that's squeezing through that hole, you see a pulsating reflection.
Pulsating with a heartbeat.
Precisely.
Yeah.
The pressure in the ear is so high that the blood vessels are throbbing right along with the heart. It's like a little beacon.
Vinod's exam is less dramatic, but more important for his diagnosis. He has a central perforation.
And this brings us right back to our safe versus unsafe distinction. The location of the hole is everything.
Okay, so why does it matter where the hole is?
Think of the eardrum like a dartboard. A central perforation is a hole somewhere in the middle, but, and this is the crucial part, it is surrounded by a rim of the original dartboard.
The donut theory. The hole is the donut hole, but the donut itself is still there.
That's a perfect way to put it. As long as that outer ring, the annulus, is intact, it usually means the bone itself isn't being eaten.
And a marginal perforation.
That's a hole that goes all the way to the edge. The donut is broken. It means the skin of the ear canal can just march right into the middle ear and start forming that bone-eating cyst we talked about.
So Vinod has a central hole. The bone is safe, but the mechanism is broken. Which brings us to the physics part of the exam. The tuning forks.
I love tuning forks. In an age of digital everything, there's something so elegant about striking a piece of metal to diagnose a patient.
Okay, so the two tests, Rin and Weber. Vinod had a Rin negative. Walk us through what that means.
So normally, air conducts sound better than bone. If I hold a humming fork next to your ear, it should sound louder than if I press the handle against your skull. That's a positive Rin, normal.
But for Vinod, it was the opposite.
Exactly. When the doctor pressed the fork against the mastoid bone behind his ear, Vinod heard it louder than through the air. That's a negative Rin.
And that tells us what?
It tells us his nerve is fine. The bone is getting the vibration to the nerve, but the air pathway is blocked. The pus in the hole are acting like a mute button.
Then there's the Weber test. The fork goes on the middle of the forehead, and Vinod said he heard the sound in his bad ear.
Yes.
That feels like a trick. Why would the bad ear hear it better?
It's the plugged ear effect. I mean, stick your finger in your ear right now and hum. The hum sounds louder in that plugged ear, doesn't it?
Yeah, it resonates.
Because you blocked out all the ambient noise in the room. Vinod's infection has effectively plugged his ear. So the vibration from the fork resonates in his skull, and he hears it in the bad ear, because that one isn't distracted by anything else.
Now, I want to pause on something called the false negative trap. The text flagged this as a huge pitfall.
This is huge. And it's fascinating. Imagine a patient has a dead ear. The nerve on the right side is completely gone. Total silence.
Okay.
You put the tuning fork on the bone behind that dead ear, the patient says, I hear it.
But how? You just said the ear's dead.
Because the skull is basically a solid block. It conducts vibration incredibly well. The vibration travels straight through the skull to the left ear, the good ear.
So the good ear is eavesdropping on the test.
It's totally eavesdropping. The left ear hears it, but the patient thinks it's coming from the right because that's where you're touching them.
Yeah.
And a doctor might wrongly conclude, oh, bone conduction is present, when actually the ear is stone dead.
Wow.
That's a false negative Rin. To fix it, you have to mask the good ear, basically make a bunch of noise in it to keep it busy so it can't cheat.
You have to outsmart the patient's own anatomy. But Vinod's results were consistent. Moderate conductive loss.
So we have the history, the visual, and the physics. We have a verdict.
And the diagnosis is?
Right-sided inactive mucosal chronic suppurative otitis media.
That is a mouthful. Let's decode it. Inactive.
Because the ear has been dry for 6 months, the fire is out, it's the perfect time to go in and rebuild.
And mucosal confirms it's the safe type. So the fix. The notes distinguish between myringoplasty and tympanoplasty.
This distinction really matters. Myringoplasty is just patching the drum. It's like putting a piece of tape over a hole in a window.
Simple enough.
But Vinod has hearing loss. We can't just patch the window. We have to check the engine. That's tympanoplasty.
So you go deeper.
The surgeon lifts the eardrum and inspects the little hearing bones, the ossicles. Are they moving? Are they eroded? We have to make sure the gearbox is working before we seal the hood.
And to seal it, they use a graft. The material of choice is temporalis fascia.
It's the gold standard. It's the tough, fibrous covering of the temporalis muscle, which is right there on the side of your head.
Why that specific tissue? Why not just a skin graft or something synthetic?
It all comes down to survival. Skin has a really high metabolic rate. It's hungry. It needs a robust blood supply immediately, or it just dies.
Okay.
Fascia is tough. It has a very low metabolic rate. It can survive on almost no oxygen while it waits for new blood vessels to grow into it. Plus, it's the patient's own tissue, so there's no rejection.
So you harvest a piece from the temple, slide it under the eardrum, and hope it takes. But there's one major condition for Vinod. The doctor gave him an ultimatum.
The smoking ban.
And this isn't just the usual smoking is bad for you lecture, is it?
No, this is about the physics of surgery. Nicotine is a potent vasoconstrictor. It clamps down on those tiny blood vessels.
The same vessels the graft needs to survive.
Exactly. We just said the graft needs new blood vessels to grow. If you smoke, you are choking off those new vessels. The graft will literally starve, die, and fall off.
So the surgery just fails completely.
It fails. Not to mention, smoking paralyzes the cilia, those little hairs we talked about. So the ear loses its self-cleaning conveyor belt all over again. If Vinod wants to hear, the cigarettes have to go.
It's really amazing to step back and look at the whole picture. We started with a guy complaining about a leaky ear,
Right.
just some fluid. But by asking the right questions, looking at the type of fluid, we navigated this whole minefield of brain abscesses, facial paralysis, dead nerves.
It just highlights that the ear is not an island. It's deeply connected to the brain, to the vascular system. A safe perforation stays in the mucosa. An unsafe one threatens the entire control center of the body.
And we figured all that out without a single MRI scan.
That's the art of the clinical detective.
Before we close the case file, is there one last thought or image from this deep dive you want to leave our listeners with?
I leave you with the reservoir sign. We touched on it, but it's haunting. Imagine you're the doctor. You suction out all that yellow discharge. You clean the ear canal completely until it's dry.
Okay.
You look away for 5 seconds to grab a tool. You You look back, and the ear canal is full of fluid again,
Open,
instantly.
like a magic trick.
Yeah.
Or a horror movie.
It's called the reservoir sign. It tells you that fluid isn't just coming from the surface, it's welling up from a deep reservoir. The mastoid antrum behind the ear is acting like a flooded cave.
Wow.
It's a stark reminder that in medicine, what you see on the surface is often just the overflow of something much deeper, hiding just out of sight.
A deep well of infection. That is a perfect, if slightly unsettling, place to end. Thanks for joining us on this investigation. We'll see you on the next deep dive.
Stay curious.